to this year's first Global Neurosurgery Roundtable webinar, where today we'll be having our very own Dr. Shabani, who is a neurosurgeon right here in Tanzania, in Moi. So Dr. Shabani is a consultant neurosurgeon, and he has worked in the field of neurosurgery for over 17 years. He has established a pediatric neuroendoscopy service for hydrocephalus and spina bifida in Tanzania. He is the co-director of the Tanzania Neurosurgery Education Program in collaboration with Weill Cornell University in New York. He is also the assistant program director of COSEXA FCS training in Tanzania. He is the NIHR collaborator working on neurotrauma multi-center clinical research. He has more than 46 publications from various fields in neurosurgery. Dr. Shabani is also a member of WFNS Global Neurosurgery Forum, WFNS Neurotrauma Committee, Sub-Saharan Network for Congenital Birth Defect Surveillance, and the Sub-Saharan Network for Pediatric Neuro-Oncology Research. Dr. Shabani, we're more than honored to have you today. Please welcome and proceed with your presentation.
Thank you very much, Dr. Mariam, and hello, everybody all over the world. Good morning, good evening, good afternoon. My name is Dr. Shabani. I'm a neurosurgeon, senior consultant, head of the pediatric neurosurgery at Moi. Today, I'm going to spend 20 minutes discussing patient care and research in progress in Tanzania. I have only one conflict of interest to share with you. I'm a collaborator here at Moi with Weill Cornell and doing global neurosurgery projects. Muhimbili Orthopedic Institute is the tertiary hospital, state of the neurosurgery and orthopedic services. It is also a university teaching hospital, and it also offers training for College of Surgeons East, Central, and Southern Africa. It's not the only hospital which is. It's one of the 5 hospitals, but it's the main hospital. Institute which collaborates with institutions abroad. The other institutes are now gearing up to collaborate with international Barrow Institute. Bugando has now started collaborations still in the pipeline.
Dr. Shabani,
This is the only training hospital. The other hospitals are not. Yes.
Excuse me, Dr. Shabani, there's an issue with
hear me?
Yeah, there's an issue with the internet. We're not hearing you very well. Is it okay if I share the slides and you just speak?
Okay. Now, Mariam?
Yes, I'm about to share my screen. Okay, you may proceed. You'll just tell me when to go to the next slide.
Yeah, just please next. Next. So, apart from training, this is the only institution, as I said, it collaborates with institutions abroad. Yeah, next, please.
Okay, I'm having trouble too trying to go to the next slide. Can you see my screen now, Dr. Shaban?
Yeah, I can see your screen.
Okay.
Can you put it in the picture mode?
Okay.
Slide mode, yes.
Okay, how about now? It's okay.
Okay, yeah. So the animation has stopped working, yeah? Okay, no problem. I'm just trying to show you the evolution of neurosurgery services as per numbers, as you can see. If you compare the number of surgeons, the number of trainees, and the caseload, the number of surgeries which have been done at MOI since 2001. You can see the number was quite constant until 2010, and then it shoot up. And if you check on that, please press next. If you shoot up, you'll notice this is the time when everything was going in shape, that our training program started, the residence program started, the postgraduate Master of Science Neurosurgery, when we trained 2 neurosurgeons in South Africa who came back. And at that time, this is when also collaboration with Weill Cornell started. And from there, you can see now the caseload going up very tremendously, and also the number of surgeons also increasing, and the number of residents also increasing. Please, next slide. This is again the same picture comparing the OPD, the inpatients, and the surgeries. I mean the specialists. Please, let's go again. Next slide. And here you can see the number of cases. Please, yeah. The number of cases were not only increasing, it was also the type of surgeries. If you compare the 2005 list, we were doing very few procedures compared to current list. You can check there on the spine. Number 2, the number of procedures rose up from the traditional elective surgery for degenerative spine to include traumatic spine diseases, minimally invasive procedures, scoliosis procedures, and now we are going further to robotic spine procedures. And then you can see cases like stroke, pediatric, and neuroendoscopy. This was the era when the number of cases, those procedures were introduced at MOI. Please, next slide. And somebody may ask, please back, yeah. Somebody may ask, how is this came about in an LMIC setup? Actually, it's through collaboration and also establishing a clinical audit. The clinical audit, actually, if somebody follows the audit, the audit cycle, the principles of audit cycle, there's an incremental improvement which amounts to major improvement over time if somebody goes through. And I can give you an example. Please, next slide. I can give you an example of spine procedures. Please, next slide, please. So if we check here, as I showed you, the spine procedures before 2015, there was no surgical procedures. So patients for spine trauma received bed rest and hollow vest for a few of the patients and the neck traction. And after lying down for 6 to 12 weeks, patients were being discharged home for rehabilitation. And this actually caused most of the affluent patients to be referred abroad for treatment because there was no spine surgery. But if you check the procedures, I mean the protocol and what we used to do after 2015, this is after we increased the number of surgeons who were trained abroad and also established a collaboration with Weill Cornell. You can see here now that spine surgery was introduced for spine trauma, and the follow-up became now in the protocol of care of spine trauma, and automatically referral abroad was aborted. And we went to do an audit. Next slide, please. We went to do an audit just to see how we stand before the collaboration. So you can see here the audit of 2016 and 17, and it was published in the Journal of Neurosurgery. Only 40% of cases received surgery at that time. This is after we already started collaboration with Weill Cornell, but only 40% of cases received surgery. Among those, 22% were public cases, so more of public compared to private. But if you check time to surgery, it was very much delayed, and the delay was actually more on public patients than private patients. So here it raises the question of accessibility to services. It was skewed to patients who who could afford the implants, and the public patients would go a very stringent mechanism of social servicing, social welfare, and finally they get the implants, but it takes very long time for them to get surgery. Length of stay was so much prolonged, and this also gave rise to more complications. And the cost of surgery was actually very high due to that. And if we check on the diagnostic, X-ray and MRI were used more frequently than CT scan. So MRI was overused than a CT scan, which is not an AO protocol. Please, next slide. The other reason for prolonged delay to surgery was the referral system. And if you can see here, please, next slide, please, next button. You can see here, no, please, back. You can see here, the time to arrival to hospital was also related to the distance from the referral system. So this actually was not something which was favorable to referring hospitals to refer patients here. And it resulted into fewer patients being treated. And we saw this reason, and therefore we established our own protocol based on the modified AO protocol just to suit our logistics in-house. And we sought for grant. Please, next slide. Next slide, please. We sought for grant, and this is how we went. Back, please. This is how we went. We increased, the aim was to increase the number of surgery from 40% to 100%. And we managed to get implants donation from the Pucindes after a grant was accepted. And we also aimed at shortening the time to surgery from 30 days to 3 days. This protocol is similar to the AO protocol, but modified to our local setup. Those patients who were favorable to surgery were actually sent for surgery compared to those who were unfavorable, who were poor prognosis for surgery. Next slide, please. So if you check here, when we received the grant, the number of surgery increased tremendously. You can see the graph from 2018. Next slide, please. The type of surgeries, the type of injuries which we were treating were ranging from all the segments. But you can see here the majority of the cases were from the lower cervical junction and the thoracolumbar junction. So this raised to the question again of quality improvement. Next button, please. Next button. Just press, yeah. You can see here. So we started again an ICU protocol, just to suit our local demand. Yeah, next slide, please. So this is the crux of having all this continued education program, which are run in collaboration with Weill Cornell, Professor Roger Hatto, who is the director, and I'm the co-director of the Tanzania Neurosurgery Project and the educational global neurosurgery education project. We aim at ensuring hands-on training for neurotrauma and neurocritical care. We do this every year, and this year we are going to do in the third week of March. Please keep abreast with foregoing announcements. We also do the fellowship and the continuous research. Next slide, please. So these are the fellows, some of the fellows who have actually visited MOI and they have done a very tremendous job. I thank them for their contribution towards improvement of the neurosurgery services. And in the picture, you can see the leadership of MOI working hand in hand with this project. Next slide, please. We receive donations and we do hands-on procedures. And each time we have visiting fellow annually. And we have actually now gone into further step to establish Africa Spine Trauma Network, which we intend to incorporate all the East, Central, and Southern African countries performing spine surgery. And this project is run between MOI, Weill Cornell, and the University of California, San Francisco, with support from SIGN, the SIGN NGO. Next slide, please. So we are not far from innovations. These are some of the innovations which we have reached so far with our quality improvement clinical audit cycle. Our hospital has acquired a brain lab. This is a state-of-the-art intraoperative neuronavigation system just to aid the surgeons performing spine trauma cases and elective spine surgery cases. And this technology actually avoids the radiation hazards which have been documented to spine surgeons, including cataract, radiation cataract, thyroid cancers, etc. Next slide, please. So it's not that everything we copy from the high-income world. The instrument you are seeing here, it costs about 2,000 or more than that in US or elsewhere. But here in Tanzania, it costs nothing because what you see here is just a modified giving set. This is IV fluid giving set, which is connected to the used infusion bottle, compressed and cause suction. And it suffices to do what the high-income countries enjoy. And we have actually developed this protocol, and it is actually safe from postoperative infection. We don't record postoperative infection in our spine cases here at Moi. Next slide, please. So we have also established minimal invasive spine using tubular retractors, and we thank the Vision from US for donating the tubular retractors, which we are now training our residents and young neurosurgeons to perform minimal invasive. And we have reached a level now that the patient's hospital stay is only 3 days. So we are now moving forward to the spine endoscopy, which is going to roll on from this year. During our courses, we train our residents on the artificial intelligence and robotics, which in the future, we are planning to incorporate this in our clinical practice. Next slide, please. So the scoliosis surgery. This is now we have 200 patients waiting for surgery, and we are planning to do surgical camps, and this is the fourth round just to occur in February. We received donations of these are very expensive implants, and we give for free to our patients. So far, currently, three surgeons are very skillful on this procedure, and we invite residents and young neurosurgeons from this region actually to join us in the surgical camp to get hands-on training and also to learn about scoliosis surgery. Everything we audit, actually we have encouraged our team that we have to publish. And you can see now that since we started this protocol, we have done a tremendous job. About 96 publications are now in circulation in the peer-reviewed journals. This is an update until July last year. And the activity of publishing, as you can see, it correlates very well to the time when we collaborated with Weill Cornell. Next slide, please. So these are some of the papers you can see. And so for each paper, we cite our SWOT analysis from the previous one, and we improve. So these are very useful articles for my fellow colleagues to read and actually develop your own programs locally. Anything, they are good and there are also challenges. As you can see, what I've shown to you, most of these developments, we thank our donors for bringing them up. And this is a challenge because sustainability does not depend on donor. It has to be inborn and home growth. So this is a challenge we are facing, and hopefully we are going to overcome it very soon. Implants are very expensive, and the vendors and our other stakeholders need actually to know that East Africa is also a place where they can market their goods, so that we can lower the implants. We can lower the cost of goods and services. Most of the researchers papers which are being published in the high impact factor journals, which are international journals. And most of these journals are not accessible to LMIC. This is also a challenge, which my colleagues may find that they cannot develop the global neurosurgery projects because they cannot access the full publication of these journals. So this is something which is being discussed in the WFNS and the other meetings, and hopefully it is going to be overcome, and very soon it will be leveled down. Next slide, please. So in conclusion, what I've just mentioned is that Muhimbili Orthopedic Institute Neurosurgery Department is an epicenter of training, research, and neurosurgery innovation in East, Central, and Southern Africa. So we welcome our colleagues to come and learn and also share experiences. We collaborate with all these countries. You can see in the map. We receive patients from all our neighboring countries, far away, even from Madagascar coming here, and also from Malawi, Zambia, Zimbabwe, Congo. So we welcome all colleagues to come here and actually learn how we do things, and we improve our neurosurgery services. And just to remember that these things do happen with inclusion of international collaborations and regional collaborations, and we can make global neurosurgery feasible. Thank you very much.
Thank you, Dr. Shabani, for the presentation. So now we'll take the questions from the chat if we have any questions. Sure. Okay, so if you have any question, you can write it in the chat area, or you can just raise your hand and ask. So while we're waiting for more questions, I would just like to ask Dr. Shabani, what do you think are the primary obstacles to conducting neurosurgical research in Tanzania? And how do you think we can address these issues so that we can have impactful and locally relevant studies?
Yeah, the one thing which I would say it's not an obstacle, is that there's a fear of publishing. Most of the residents who we train right now, we have tried to alleviate the fear of publishing. That anything you encounter in your clinical practices, this is something you can collect data, and you can read other people's work and improve on your data analysis and publish. So that's the only obstacle, not a big obstacle, but something which can be overcome over time. And there's a very big opportunity to young neurosurgeons actually to publish in the journals, because our experience is quite different from the high-income country experiences. We have a lot of cases with clinical presentation which is against the textbook material which we read in our textbooks. And these are the good things which we can share in the conferences, attending the conferences, and the publishing.
Thank you. Do we have any examples of some neurosurgical research that we have used to influence clinical practice or policy making locally and globally?
Locally, the protocol of ICU, that is something which has now entered into the ministry. Before that, ICU care for spine trauma was not something which was in the pipeline. So ICU was just considered for cardiac failure, diabetic ketoacidosis, and obstetric emergencies. So now it is coming up that even traumatic brain injury, spine trauma, these are also require ICU care, especially those cases of spine injury with the spinal shock and the cardiogenic shock. So that's something which we boast of. It has come into our changing in the clinical practice.
I see someone wants to ask a question. So please, you're welcome. Please mute yourself, unmute yourself and ask the question.
Shazin Khan wants to ask a question.
Yes, thank you so much, Dr. Shabani, for the talk. I was just wondering, is there a localized effort to sort of collaborate with entrepreneurs or other local actors in order to start producing the necessary devices in the locality instead of potentially importing them from more expensive locations, or is that more of a naive question to be asking?
Yeah, this is something we are advocating. It hasn't gotten from the drawing board into practice. So the government, what the government has done so far now is to attract investors. So we have a section which is under the president's office, specifically which fast track whoever wants to invest in Tanzania with the capital of more than 100,000 US dollars. So we invite anyone who wants to come here. You can see the policy is now even the taxation system has also relieved the investors. The cost of electricity is going down. So the government is also investing in roads, and on all this actually attracts investors. Anyone who wants to come here and produce these implants locally, and even exporting. We have a common marketing umbrella under the East African community, which consists of 5 countries, South Sudan, Kenya, Uganda, Tanzania, Burundi, and Rwanda. We also have the SADC, Southern African Development Corporation, which has many countries more than the East Africa, which we share the common tariff. And this is the environment which any investor who wants to actually build a factory here in Tanzania for these products can have all this access to market. Because all these markets are open to Tanzania, and these are the landlocked countries. They use our port in Dar es Salaam to ferry their goods from the east and all over the world. So it's a very nice place to invest for anyone who wants to invest in the manufacturing of these spine implants. I actually encourage whoever is interested in doing that to please take this opportunity as quickly as possible.
Thank you, Dr. Shabani. From the chat, we have questions. So Shakirullah is asking, is there any opportunity for other African neurosurgeons for fellowship training in your hospital? And there's also another question asking the same for spine surgery training at MOI.
The fellowship we offer at MOI is through under COSEXA. This hospital is accredited to COSEXA. So for someone to have a proper fellowship at MOI has to register with COSEXA. Currently, we don't have those short-term fellowship courses which are accredited by MOI as a teaching hospital. So, but we can still accept visitors who wants to come here as 1 month, 3 months, 6 months clinical acquaintance. We teach our fellows. We have received fellows from Zimbabwe. They stayed with us here for pediatric endoscopic surgery, and they went back. So we still invite whoever wants to come here, but that short courses do not have any certificate. We also we have a special fellowship for European and Canada and US. This is a global neurosurgery fellowship which is being sponsored straight by Weill Cornell. So anyone from those regions I've mentioned, they can apply through the Weill Cornell website or our website to get the placement. We receive one. We usually save one fellow every year.
Okay. Thank you, Dr. Shabani. We have another question from Sawe Kelvin. He says, thank you. And also he has the question on what is the plan to train more local neurosurgeons, considering that in Tanzania, they will have to go through general surgery training first, which now is increased to 4 years, then 3 years of neurosurgery training. Do we plan to go for neuro training direct like other countries such as Kenya and Uganda?
We have done our homework, and actually this year, very soon, I think in April or earlier than that, there will be an announcement for MED neurosurgery, which is registered under Muhimbili University College of Health Sciences. It will be a 5-year training course with the opportunity to go abroad for fellowship. And I'm just whoever is asking that question, and the young fellows, please keep abreast. It is going to be announced very soon. We have prepared that course, and it has been registered. It is just waiting for announcement.
Thank you. There's another question from Marcus. He's asking, how do your implementations of robotics and AI help to improve the quality of neurosurgery? Are there any ongoing research projects or implementations to be incorporated using robotics?
Yeah, actually, once we finish the training, there's a training program now with the AI. I showed you the slide there. But one step has been gone. We have gone one step ahead. Using the Brain Lab Neural Navigator is also one of the robotic pathway, and number one, it shortens the time to the time of surgery. The duration of surgery is shortened. Number two, it avoids complications, post-op complications. And number three, it is safe for the surgeon. It eliminates the risk of radiation. If somebody pursues a spine surgery as a subspecialty throughout his career, getting radiations maybe 3 times a week or 5 times a week, this is not healthy, because you are exposing yourself to radiation cataract and also thyroid cancer. So these are the benefits of robotics.
Okay, thank you so much, Dr. Shabani. I see that we don't have any further questions. So our next webinar will be on the 20th of February. We'll be featuring Karen March, who is a retired RN and a global educational consultant. and she'll be speaking on global neurosurgery and nursing education, challenges and successes. Thank you everybody for calling in today, and have a good evening.
Thank you all.
Thank you.